Welcome back, Journal Clubbers. Ed Bowder and Dan Schwester on the Overrun, talking about
Hey, everybody.
modern EMS medicine. Today, we're coming at you with a new study that came out in January of this year. And let's go ahead and talk about how we can fix trauma patients in the field. I'm really excited about this study. Danny, you and I have looked over this for a little bit. This is faster refill in an urban EMS system, saves lives, a prospective preliminary evaluation of a hospital advanced resuscitative care bundle. The advanced resuscitative care bundle is referred to as ARC, and this is from Broom et al., and this is out of the great state of Louisiana, the system of New Orleans that we're all familiar with. Shout out to the NOLA EMS people. So this study, in brief, looked at the usage of this ARC bundle, which was 2 units of packed red blood cells, 2 grams of calcium, and 2 units of tranexamic acid during resuscitation. And these are some good outcomes. Danny, what do we think about this so far?
I think it's a really promising study. I think they did great work. It's interesting once we delve into the details of learning about exactly how this worked out. But significant improvements to mortality, decreases in pre-hospital intubation, and overall just better outcomes for patients. It was with not a lot of time investment. So I was really excited to see this. I think this is the way of the future. I think they've caught lightning in a bottle.
And that's the most important thing, right? So trauma resuscitation is something we talk a lot about almost arbitrarily, right? Like we kind of talk about like we don't really know what we're doing, so we should probably just not do anything. And military studies have kind of debunked that, right? So we see military data where it's like, no, give blood, tourniquets, TXA, stop. If someone is bleeding, stop them from bleeding, and they should go on and get better. So yeah, let's talk about some of the military background, and then we'll get into this into more of the meat of the paper.
Yeah, definitely. We've learned from the military, from their far forward and their point of injury care, and through TCCC and the things that they've adopted, that doing things at the scene make a difference. The question is what makes a difference and what's going to get you a benefit on the backside. I think the old way you used to think about it was scoop and run or stay and play. I think we've changed to a return on investment model where what we're putting in, we want to get something on the back end, and we want to get more than what we put in. We want to make money. And for us in trauma care, making money is buying more time for the surgeons and the intensive care people to do definitive care. So if this is stuff we can implement in the field and it translates to a survival benefit or buying more time for that patient, that's a win.
And absolutely. And this is something where the biggest time investment that you see is there was a 3-minute difference in the patient care group. So you had the patients that didn't get the ARC bundle, their time was 13 minutes to the hospital, and the patients that did get the ARC bundle, their average time was 16 minutes. Now, again, this is in New Orleans. This is a large city system. So, they're pretty close to trauma centers, which is an important factor to consider. But getting into the meat of this, now, again, here you see kind of in the abstract, it talks about things, but the meat of the takeaway is this. There are already 2 trials, the Pamper trial and the STAMP trial, that looked at using TXA in the field, whether it would be effective, whether it would improve outcomes. The long and the short of it is it does. This paper, and again, this came out in January of this year, and this is out of J Trauma and Resus, and it'll be linked in the show notes. This talked about, you have these patients who they had a systolic of less than 70, or they had a heart rate of greater than 90, so essentially a shock index greater than 1. And in this treatment, they were looking at, all right, so we'll go ahead and give these packed cells, calc and TXA, through this rapid infuser and see what the outcomes, I guess, what was elucidated from the patient care aspect from that.
Yeah, they basically looked at it as we would calculate a shock index. If anybody had a systolic blood pressure equal to or less than 70, they get this bundle. Or if their systolic is less than or equal to 90 with a heart rate of 110 or greater, they get the bundle. So they're really covering kind of both things, that really shocky, bad, low MAP patient, and then that other one that may be compensating now but won't be.
Yeah, and this was their evaluation here. So again, we have 210 patients in the analysis, 61 got the bundle, 149 controls. Again, this is all the discussion that will be linked. And earlier I misspoke. This is out of J Trauma Acute Care Surgery. These are the demographics in the study, which I really thought was interesting because it's a pretty almost homogeneous kind of blend of patients, where
Yeah.
the mean age was very similar. Not surprisingly, a lot of the trauma patients were male. Um, and there wasn't a huge difference in any of the vital signs that you see along here. Here it mentions a 3-minute additional pre-hospital time was in the ARC group was to give a second unit of packed cells. And here we see some of the graphs here and some of the limitations. Now, going through this, and I just want to look at this conclusion here, while it talks about the ARC bundle being included in early transfusion recommended military guidelines, they looked at this and it says, okay, now that we've done it in a civilian setting, and there hasn't been a lot of previous EMS studies in the civilian setting, we see that this might actually work. This might be something that we have to work with. And what I really liked about it was the authors took the time to say this study presents the first evidence of reduced mortality when pre-hospital transfusion is achieved within the platinum 10 minutes within an urban ground EMS system, highlighting the need for further investigation into implementing ARC closer to the point of injury. And that's that'll do it for the quotes from the paper. So let's kind of get into this now. These patients, right? So we know that they're traumatic injuries, right? We know they're hemorrhagic injuries, and that platinum 10 minutes is talked about, whether you're talking about T-TRIP or you're talking about PHTLS or any of those pre-hospital trauma courses. We talked about scoop and swoop, where it's almost like get them to the hospital, right? Hot lights, cold steel. This is the only thing that we need to do for these patients. And
Phil Bolus.
Exactly, right? And for a long time, I feel like the conversation in trauma and EMS was, all right, if they're bleeding, just go to the hospital, right? Traumatic injury, hospital, hospital, hospital. And there was always kind of this gap of, well, what can EMS do? And this paper, and again, if you want to argue that 210 is a small N, I disagree with you, but I understand the argument, right? And you've got 61 patients in this group, 2 units packed cells, 2 grams of calc, and TXA. 98% of these people received 2 units of packed cells. 97% got 2 grams of calc. 74% of the patients got TXA, which I think probably has something to do with the infusion time for TXA. But all these patients in this ARC bundle, when they got to the hospital, decreased heart rate over standardized trauma patients without the ARC bundle, decreased incidence of endotracheal intubation among the pre-hospital population. In hospital, there was no real difference in the intubations, probably because patients who needed to be intubated were already intubated. And it's whatever. So you see decreased heart rates, decreased endotracheal tubes, decreased 24-hour lengths of stay, decreased 24-hour mortality, decreased in-hospital mortality. So when we ask these questions of what is the actual tangible benefit of a treatment bundle, this is it, right? Like this is it. Here's a bundle that actually shows improved outcomes. There's going to be an argument for cost because packed cells cost money, but if we're carrying things like TXA, and if you're in a system that has packed cells, and you're carrying calcium, it seems kind of silly to not try to implement this sort of protocol.
Yeah, definitely. I mean, the protocol's pretty straightforward. It's packed red cells, which I'm interested in somebody doing a follow-on study with whole blood and seeing if we get even more of a benefit. The calcium chloride, because most people in active hemorrhagic shock are hypocalcemic. Remember, calcium improves contractibility of the heart muscle. It improves cardiac output that way. And TXA, a antifibrinolytic, does not cause vaso-occlusive events down the road. I think that's been pretty much borne out in the studies. There are some people still a little worried about giving it, but generally, going back to CRASH 2, we're going on almost 15 years of data that shows TXA is good for trauma patients. It's a good bundle. It makes a lot of sense, and they got some really good numbers out of it.
And you're right about the whole blood thing. I tend to think that if we did this with whole blood, it would probably show even better outcomes. Because we've had the arguments about component therapy and like what works and what doesn't. But in this type of setting, right? Because I think we work very hard in EMS to try and do cognitive offloading for cardiac arrest, because that's the common and sexy thing, right? We've got our airway rolls, we've got everything that you need is all set in one thing. And even though some shops have like stop the bleed kits, it just isn't the same as what they're doing here, where you're going off to a trauma, you know that you have this package available to you, and all right, let's see what we can do to actually fix these patients and make them better. Going into a scene, and you and I have done this going out to jobs or to calls. Sorry, Jimmy. going out to calls where it's like, okay, so we've got this happening, right? We know that, all right, this is a trauma, so maybe it's a hemorrhagic incident. We know we're going to have to give them fluid, or we know we're going to have to give them blood. We know that we're probably going to have to work on resuscitating their muscles, which are losing all the different things that will help them contract, like calcium. So having this bundle, I think, also improves the conversation going into the call. So if you know
Definitely.
you're going into a trauma and you have this tool available to you, obviously, you're going to get these treatments sooner. And again, these aren't like random suburban EMS systems. These are 16-minute patient contacts that in that 16 minutes, they're showing these improved outcomes using these bundles. So it kind of pokes a big hole in, well, I have to stay on scene to make sure this patient gets treated better, or I have to fly to the hospital without actually doing anything because I can't do anything to fix the patient. This is one of those kind of gray area studies where this is what EMS can do, and this is what EMS does very well.
Yeah, absolutely. Remember what I said earlier. It's a return on investment. Pre-hospital care needs to have a payoff on the back end. And that payoff can be anything from length of stay, it can be length of morbidity, it can be less ventilator days, it can be less surgical intervention. Anything that improves the patient's outcome is what we're shooting for. So they probably already have a good foundation of doing the basic things, the fundamental things that have to be done in penetrating trauma, which tourniquets, wound packing, stop the bleed, chest seals, things like that. At the EMT level, at the paramedic level, we're incorporating this stuff, and they saw a benefit. So this is something where we should really be excited about this. And this is something, if you have the ability to, or if your program's considering something like this is a great study to use to engage your medical directors and your clinical leadership, because it does show things. And it also, I was really impressed. This is an urban center. This is that classic, hey, we're 5 minutes from the hospital, just throw them in the truck and go. They didn't do that, and they got better outcomes.
No, exactly. And I think it's important that this came out of New Orleans too, because this is something that we can get eyes on this, right? We know that all the people down in New Orleans are on television a lot, which is great. We have our own, conversations about that. But knowing that this can improve the outcomes of these trauma patients, this is one of those opportunities that we have as an industry where, and you never want clinical conversations to move into industry talk, right? That because then it kind of dehumanizes people. It's easy to talk about ROI in healthcare, and have it seem more like like kind of like counting nickels, like those kind of things, or counting peanuts, whatever, from the accountant bean counter side. But considering the only thing in this paper that talks about the gap in care is that that additional 3 minutes, right? Where your non-ARC patients had 13 minutes of contact, your positive ARC patients had 16 minutes of contact. But those 3 minutes can benefit that patient 30 minutes, 30 days, 30 years, and
Who knows?
And who knows? And that's where that ROI comes in, where, and this isn't something that is new to medicine, right? We do this all the time in the field. We try to increase ROI in patient care. Why are we giving nitroglycerin to chest pain patients? Because we want to try and vasodilate them. We want to try and get more oxygenation to their heart muscle, because we want more of their heart muscle to survive when they get to the hospital, right? If I've got a closed head trauma, why are we RSIing them? Because we want to decrease their intracranial pressure and increase their oxygenation ventilation. If I've got an asthma patient, why are we giving them albuterol in the field? To increase their airways and to increase their oxygenation. When we talk about the purpose of EMS, this is literally the thing that we're talking about, right? Sending us out to get to these patients who are critically ill, who need treatment, and whose outcome we can improve by getting them care faster. That's what we do in EMS. And it feels like this paper is saying, like, if you're an EMS provider, this is probably the thing that you should do. Right. And it's what's frustrating, from at least from my end, and I don't mean to speak for you, Danny, is that this has been the trend. Right. There hasn't really been anything when it comes to, and we know that whole blood is probably better than component therapy. Right. We've talked about that previously on journal clubs and in episodes before. But if that's not the case, okay, give them component therapy, right? If you don't have whole blood, give components. If you don't have components, go to the trauma center. But if you do have these tools, we have to use them in order to improve these patients. And it seems like, and again, we're doing this now in June of 24 on a paper that came out in January of 24, because this isn't going to hit the textbooks for another 5 years. So, we always talk about hope at the end of the episodes. How do we maintain hope that this eventually gets out into the field? Because aside from us screaming into the void, how do we get this out to providers and to management?
I kind of look at it differently. I think the stem is turning. I think we're moving
You're
into
much more optimistic than I am.
Oh, absolutely. Absolutely. I'm looking at this as this is some great work. People are going to look at this. People are going to replicate it. I have no doubt that the data is probably going to replicate in other studies. Like I said, I'd be really interested to see how they do it with whole blood, how they do it with other modalities. I don't know how they gave the TXA. That's another thing we're learning we can do at push dose. That's something that came out of the military. There's a lot of things, a lot of variables to play with here for the best cocktail to take care of our patients. The important thing is we now have something definitive that we can do that will benefit patient outcomes, and we should be excited about that.
And something I think is kind of fun and interesting is, remember I say a couple years ago, it's probably a decade ago now, where we were arguing about we shouldn't give blood or component therapy because the citrate in it will increase acidosis. No, we can't do that. And it's interesting how that was the debate a decade ago.
Better than crystalloid.
Exactly right. Exactly. And again, that was the argument, right? We're all right. So we're giving saline or ringers, and okay, well, they don't have oxygen carrying capacity, and they're damn it.
Yeah, it's PRBCs have a hematocrit or a hemoglobin of 36 or something, and I'd have to pull the numbers, but it's a lot more than saline.
It's a lot more than zero. Exactly.
Yeah.
And I think that's kind of the thing to take home from this, is that even if you're working in a system that is looking to reevaluate your trauma care, you're looking to reevaluate what we can do pre-hospitally for trauma patients. If you don't have whole blood or component therapy, you have to talk to your clinical team about seeing what you can do. If you're in New Jersey, almost all paramedic systems are hospital based. If you're in a hospital system that has packed cells, or if it carries whole blood in their trauma departments, there should be a conversation about how can we get those. Lift. No, exactly. How can we get those out to the truck? And again, that you might have to do, logistics on how to do that.
Sure.
But at this point, if you have a system like New Orleans, where we're trying to lean in to better patient care, better outcomes for everybody, and that's what we're going for. Yes, there's a financial component. Yes, there's a monetary component. And while we are seeing things where perhaps there's some light of what's left of the American system, we do operate in a capitalist economy, so we do need to generate some kind of revenue. But my argument to that is, if your clientele, if your patient base dies, they're not going to give you any money. But if you have someone who lives from wherever illness or injury they have, they can still pay you money. So even if this is a financial ROI argument, you want to keep the patients alive so that they can keep coming back to the hospital. And this is where
check out that sweet rehab money.
Exactly. And that's kind of the thing. So this is something that you can bring to administrators and be like, hey, listen, EMS is a loss leader for most systems, but this is a place where we can take this trauma patient, take them to the trauma center. If you're worried about reimbursements, you're going to get reimbursed, and then we can make these patients better, and then they can keep coming back to this hospital system. And that's where my business mind starts to explode, because it's this. I don't understand how you can make the argument that dead people make you more money than live people.
Well, they don't, but it's also about controlling costs, and I get that aspect of it. But again, from a clinical perspective, this has a lot of good data behind it. I think this is something really optimistic, and I think, like I said, I think you can sell this from a business perspective of, I would bet these people probably get out of ICU quicker than others. I would bet they probably spend less time in the hospital. I would guess they probably have less complications. We don't know that. I'm extrapolating from, we're assuming they get better, quicker.
Right.
Those are all good things for hospitals.
And good for patients, which is the whole point, right? But yeah, this is the ARC trial. This is from 24. This is coming out of J Trauma and Acute Care.
Great work.
The paper will be listed in the show notes. Terrific work from these guys. Really excited to see what kind of follow-ups come from this.
Definitely.
Jacob Broom is the principal author on here. This will be linked down in the description in the show notes. Let us know what you guys think. Are we using packed cells? Are we using calcium? Are we using TXA enough? Comments down below. Be sure to click subscribe. That's going to show up somewhere in this window after 6 months of doing this. I still don't know where it's going to be. But let us know what you all think down in the comments. Click on the study, check it out, congratulate the authors. Definitely. And that's Journal Club for this week. We'll talk to you all next time. And for the Overrun, I'm Ed Bowder.
I'm Dan Schwester.
We'll talk then, guys. Have a good night.